Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary. For the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the glomerulonephritis. Glomerulonephritis is the infection by bilateral disease of kidney, which usually affects all the glomeruli. It is of three types, as proliferative, minimal lesion and membranous glomerulonephritis. Three forms are indistinguishable from each other. Proliferative glomerulonephritis. This condition is defined as the diffuse inflammation of the glomeruli of both kidneys. Acute glomerulonephritis or acute nephritis refers to the sudden onset of the infection. Proliferative glomerulonephritis is applied when the onset is insidious. Majority of cases are of infection of hemolytic streptococci of types 12, 49 and 57, which are responsible for tonsillitis, scarlet fever or upper respiratory infection. It may also be due to the virus and other microorganisms. Clinical features. The onset is usually abrupt, puffiness of the face, low output of urine and it is blood stained. General signs of acute infections are also present like fever, malaise, etc. Breathlessness may be present due to pulmonary edema. Epistaxis may sometimes present. Sometimes discomfort in renal angle may be present. Pale puffy face gives an appearance if diagnosis. Edema around the ankles and in severe cases effusion occurs into serous sacs. In adults the onset is insidious and starts as progressive tiredness, edema of lower limbs or may be asymptomatic. Cardiovascular symptoms may be affected as hypertension, rise in the jugular venous pressure, outward displacement of effect with soft apical systolic murmur, bilateral basal crepitations and reversed splitting of second soft. Some cases present with hypertensive encephalopathy due to cerebral arteriospasm and edema characterized by the headache, restlessness, transient blindness, vomiting and generalized convulsions. Retinal examination reveals papilledema, hemorrhages and exudates. Urine. Usually the output of urine is 300 to 700 ml per day due to reduction in the rate of glomerulofiltration and increased tubular reabsorption. Inuria may occur in very severe cases. The urine may look red or smoky due to presence of blood and the blood is concentrated. Protein in the urine is seldom more than 4 grams per day, but the amount present is out of proportion to the hematuria. The urinary sediment in a microscopic examination shows erythrocytes, leukocytes, epithelial cells and granular cache. Renal function test. The specific gravity of urine is high as in early stages of renal concentrating power is not impaired. The concentration of urea in blood is raised as the rate of glomerular filtration is reduced. When recovery occurs, the filtration rate is rises and the blood urea comes to normal. Treatment. 3 are steps of treatment: rest, diet, diet regulation, and elimination of infection. Rest, rest and warmth. Bed rest and warmth to the patient are compulsory. Rest advised till the hematuria, hypertension, edema, and proteinuria are subsided, which may take about 4 weeks. Diet regulation. Protein restriction controls the degree of uremia. Complete restriction of protein and adequate energy intake from carbohydrates and fat ensures minimum protein breakdown. Reduction of 20 to 40 grams a day of protein is recommended. Fluid and electrolyte balance. In moderately severe cases, fluid and electrolyte balance is to be maintained. Fluid should be restricted while edema is present to half liter a day and the previous day out of output. In case of pulmonary edema, fluid should be withheld completely. Food. Food should be given in the quantities as the patient desires and consisting of carbohydrates, fats like bread, biscuits, cereals, jam, syrup, sugar and vegetables. Less than a pint of milk per day also recommended. Sufficient protein is present in such foods to reduce the breakdown of body proteins for essential needs to a low level. Salt. Salt should not be used in cooking, not added to food if the edema is severe. Otherwise, low salt diet may be advised. In severe cases where the above measures fail, treatment of the cause. The underlying cause is to be treated first. Oliguric phase. Kidneys are forced to secrete urine by giving large amounts of fluid intravenously or by use of osmotic diuretics like sodium sulfate or surgical renal decapsulation undertaken to relieve internal tension. When hypertension and hematuria have subsided and diuresis is occurred, a light diet with moderate restriction of protein is given for few days. Elimination of infection. Streptococcal infection is treated with benzyl penicillin 300 milligrams twice a day by intramuscular injection for 5 days. Removal of infected tonsils or other septic foci are delayed or postponed. If carried out during infection, it may be exaggerated. However, in few cases, symptoms subside only when the primary focus, like a chronic abscess of apex of tooth. In case of operation, benzyl penicillin is given on the day and few days after the operation. Minimal lesion glomerulonephritis and membranous glomerulonephritis. These conditions are usually described together because they are clinically indistinguishable at the onset. These are associated with an increase in the permeability of glomerular basement membrane, leading to proteinuria. It is often so severe that hypoproteinemia and edema develop. It is believed that some abnormal immune process plays part, but there is no proof. Clinical features. The onset is insidious. If the proteinuria is slight, may persist for months or years. When proteinuria increases, edema occurs and the attention is drawn. The edema is generalized and involves the subcutaneous tissue, serous sacs, and then lungs. Face is pale and puffy. General health remains normal for some time and then deteriorate progressively by infection of edematous tissue and serous cavities. The urine contains protein in moderate amounts, though about 30 grams is excreted per day. Microscopic examination reveals granular and hyaline casts. RBC may be rare or absent. Urea, it may be traces or absent. Plasma cholesterol commonly ranges to 300 to 500 milligrams per 100 ml. Plasma and ascitic fluid look milky and due to increase in fat and beta lipoproteins. Total plasma proteins are greatly reduced to 3 to 4 grams per 100 ml. There are quantitative changes in various globulin fractions, but chief reduction affects albumin. Proteins of large molecular weight like X2 globulinate retained in the blood and hence are increased relative to other plasma proteins. The resulting fall in colloidal osmotic pressure of the plasma is responsible for the massive edema. The ensuing oligemia stimulates the secretion of aldosterone, which promotes further electrolyte water retention and sometimes potassium loss. In the early stages of the disease, renal function tests reveal no impairment of glomerular filtration rate or of the ability to concentrate the urine. Differential diagnosis: proliferative glomerulonephritis, nephrotic syndrome, amyloid disease, poisoning with drugs like mercury, gold and thyroxidone, renal vein thrombosis, quartan malaria, tumors, cardiac failure, chronic glomerulonephritis, nephrosclerosis and hypoproteinemia are to be kept in mind. Treatment: relief of edema, protein intake. Till the blood urea is not increased, a liberal intake of protein is desirable, and in an attempt to make good the urinary loss of proteins, at least 90 to 100 grams of protein per day should be given. This may be supplemented with casilon and lanolac, which are salt-free protein concentrates. Salt intake: it should be restricted by prohibiting the extra table salt, avoiding the salty foods and reducing the amount used in cooking. As the patients could not tolerate, some relaxation may be allowed. Diuretics. Diuretics are of great value in controlling the edema. Thiazide, thiazide diuretics, furosemide or ethacrynic acid may be equally effective. Resistant edema. In case of resistant edema, plasma, salt-free albumin or dextran intravenously may be given. Spironolactone. It is indicated in patients with marked features of secondary aldosteronism like hypokalemic alkalosis. Control of proteinuria. Prednisolone should be given in dose of 1 milligram per kg per day for about 3 weeks and then reduce it to about 1/3 of this dose for at least 6 months. In case of recurrence of the disease on stopping the prednisolone, cyclophosphamide can be used in dose of 3 milligrams per kg per day for 3 to 4 months. Membranous glomerulonephritis. For membranous glomerulonephritis, corticosteroids, cyclophosphamide and other immunosuppressive drugs are ineffective. That's all about glomerulonephritis, and in the next video I will discuss about some other disease